name, as Lisa said, is Darlene Bolivar, and I'm one of the co-chairs of the National CAPC Patient Safety Collaborative. I'm at the IWK Health Centre in Halifax, and my co-chair, Dr. Fergal McGee, is also on the line coming to us from the middle of the country in Saskatchewan. So it is my pleasure today to bring this presentation to you, and under the auspices of disclosure, I have to say that I was one of the people that worked on leaning and fixing our system for those patients and families who are unfortunate enough to have a medical examiner experience. And so I wanted to just let you know that. I do have intimate knowledge of what Dr. Wood is going to present with you today. We worked on this for about a year to try and get it right for our families, and I would like to just acknowledge Elias was a little one of our patients that experienced using the medical examiner's services, and his family was instrumental in providing feedback, being open, reviewing all of the work that we did to make sure that families in the future would have a different experience than they did. So we are very thankful to that family and want to acknowledge them. So that's my disclosure for the day. So Dr. Wood, Marnie Wood, is originally from Amherst, Nova Scotia, and she graduated from St. FX University and is very proud of her X-ring. She obtained her medical doctorate and residency at Dalhousie University in pathology, and then she headed to Virginia for a fellowship in forensic pathology. She returned in 2008 to begin a practice as a forensic pathologist and a medical examiner within the Nova Scotia Medical Examiner's Service. She very much enjoys the teaching part of her job. She's been appointed as assistant professor in pathology at Dalhousie University and an adjunct professor in forensic sciences at St. Mary's University. And those are both two universities located in Halifax. She has presented to undergraduates, medical students, and medical residents, and at numerous conferences and courses for allied professionals. And when time allows, she hits her cottage or checks for more distant destinations that are on her must-see list. As I said, Dr. Wood was instrumental in helping the IWK, working with us to make the system that we use better. And the presentation today will focus on work that was done with the Medical Examiner's Office at the IWK, but absolutely has transferability for across the province of Nova Scotia and really across the country of Canada. So I will turn it over to Marnie now, and she's going to walk you through the process that we used and the outcomes that we've come up with. So Marnie, over to you.
Thanks very much, Darlene. I hope everybody can hear and see everything all right. Let me know if not. If there are questions on the way through, let me know that they've been typed and I'll address them, and otherwise there should be time at the end. As Darlene said, we were unfortunate enough in Nova Scotia to have several pediatric deaths close together in time, and it highlighted a need for some things to be streamlined a bit to make the experience for everybody involved better and to make the investigation go much more smoothly. So the flow chart that I'm presenting is one that, as Darlene said, we came up with for the IWK Health Centre. And so this presentation is very much focused on the Nova Scotia experience, Nova Scotia legislation, but it should be fairly easily transferable to other medical examiner and coroner jurisdictions. I'll present a lot of case examples and a lot of the background from our legislation and a lot of the information that our decisions were made on with regards to the actual formation itself. So I'm going to go over the Nova Scotia Medical Examiner Service, our case flow and our decision-making process, which again was the bones flow chart that we came up with for the IWK and for the actual IWK procedures. And I'll go through our Nova Scotia Fatality Investigations Act, which dictates as a medical examiner my responsibilities, my jurisdiction, and my authority to undertake our investigations. And again, some reportable deaths with fictitious case examples, and a bit around the hospital responsibilities regarding medical examiner cases specifically. And again, that's meant to provide a bit of background and a bit of understanding as to why the different components and different decision-making branches of the flow chart are present. So in Nova Scotia, we have a chief medical examiner, a deputy chief medical examiner, and Dr. Bose is our chief, Dr. Eric Mont is our deputy chief, and myself. It's a centralized service here in Halifax, so all medical examiner cases come to Halifax for investigation, and all three of us are forensic pathology fellows who work full-time as forensic pathologists. We have an executive director, we have a staff of nurse coordinators and nurse slash paramedic medical death investigators who do a lot of the upfront scene investigation, a lot of the legwork in collecting information for us as medical examiners to help us complete our reports and complete the certification of death. And they are also the ones who do a lot of the liaising with family members, both at the scene and over the phone, in relaying autopsy findings and relaying the results of our investigation. They also do a lot of the interaction with medical staff at hospitals when they attend scenes and when they call for information from doctors and nursing staff and other health professionals. So we rely very heavily on them to collect the information. We also have a wonderful records IT admin staff. We now have a full-time forensic photographer, and we have wonderful morgue staff who help us with the actual performance of autopsies out back. And like most offices, we have a huge menu of students of various types who come through and are a great resource to us. And as noted, I do very much enjoy the teaching part of my job. Just by way of self-promotion, this is our brand new building in Dartmouth, Nova Scotia. It is a standalone medical examiner service facility, and we've been here for just over 2 years, and it's working very well, and somehow we ended up with a functional and a beautiful building that has won the architects who designed it a provincial award. This is the flow chart that is the product of, as Darlene alluded to, a lot of work that went into figuring out what decisions needed to be made around medical examiner cases when the death occurred in hospital, and how to make that streamlined and how to make it possible for people in the middle of the night when things are chaotic and clearly deaths can be very upsetting. How do we make it simple and straightforward for people to follow the rules and to get everything done that needs to be done in a way that is beneficial to families, to the medical examiners, to the medical staff. And so I'll go through the different components of this and again try to provide through case examples and our legislation an illustration of why some of these parts of the flow chart exist. So it starts with the declaration of death in the hospital. So, the hospital, in addition to it being my responsibility as the medical examiner to identify a deceased individual, there is some necessity for the hospital to have some continuity around the patients who are in the hospital. And so the necessity of having a clinical armband present on the body came to light. And I don't have jurisdiction over the body until death is declared. And so it's often easier if the clinical armband is placed on before death is even pronounced, and then that stays on there and meets a lot of the criteria around the clinical identification of the patient. Once death is pronounced, there needs to be the question asked whether or not the case needs to be a medical examiner case. And I will keep saying medical examiner because, again, that's the type of service we have in Nova Scotia. Other provinces will have coroner's services that would be doing a very similar parallel role to ours. And so if it's quite clearly, the clinical team are quite clear that it's not a medical examiner case, then there are procedures specific to the hospital that need to be followed when a patient dies and isn't a medical examiner case, and that's a separate flow chart from this one. If there's any question whatsoever, we invite people to call our office. It's easier to make the call and decide whether or not it's a medical examiner case sometimes than it is to go back after the fact and decide that it should have been a medical examiner case. And the phone number is right there to make it easy. Again, if the medical examiner service declines the case, it goes back to the routine death of a patient in the hospital flow chart for that facility. And this is the circle highlighting that part of it. The Nova Scotia Medical Examiner Service, it's sort of intuitive, but I like to say it anyway. We don't take jurisdiction until death has been declared. We have no role in declaring death, unlike on TV where the coroner or the medical examiner arrives and pronounces the patient dead. That occurs by the clinical staff or the paramedics on scene and happens before. And once death is declared, that's when we have jurisdiction. And we have jurisdiction in Nova Scotia over any death that occurs in Nova Scotia. And that's the same in New Brunswick for the coroner system and PEI for the coroner system. If the death occurs in that province, it becomes the jurisdiction of that province's death investigation system, regardless of where the patient originated from. And in our tertiary care hospitals, we often have transfers in from New Brunswick, from PEI, and it still becomes a Nova Scotia Medical Examiner Service case if it falls under our jurisdiction here. If there is a suspicion of criminal activity, any crimes that occurred in other provinces are investigated by those police from that province. So while it's a Nova Scotia Medical Examiner case, we may be working with New Brunswick or PEI or Newfoundland policing agencies. So that's a little background just over the declaration of death. At the IWK, in addition to the flow chart, there is, this is bright red in real life, there's a sheet that reminds people of the things that should tweak them to call the medical examiner service that would make it a medical examiner case. And I'll go through this to illustrate the cases later on with case examples, but it's a nice addition to the death of a patient package that sort of gives people hints to remind them when to call the medical examiner service. Our medical examiner service, like any death investigation service anywhere in the world that I know of, is available 24 hours a day and 7 days a week. The deaths occur all the time and need to be investigated all the time, and so I provide our phone number, which incidentally, if you have questions after this presentation that you want to get in touch with us for, that is the main number, the 424-2722 number for Nova Scotia. Again, each province, each death investigation service has its own provincial legislation under which it operates, and that's in Nova Scotia operate under the Fatality Investigations Act. And again, that gives me as the medical examiner and my investigators my responsibilities that I have to meet and the authority and jurisdiction to meet those responsibilities. This part of the Act, 5.1, gives me the questions that I, as a medical examiner, am expected to answer at the end of my investigation into any death that falls under my jurisdiction. And so I have to investigate and establish who the person is who's died, when and where they died, the cause of death, which is the disease or the injury that led to their death, and the manner of death. Was it an accident, a homicide, a suicide, or a natural death? And it's also implicit in the Act that I have to answer some case-specific questions. So often the cause and manner of death are fairly apparent in some homicides and some suicides, but there may be other forensically significant questions that other investigating agencies want answered that I, with my medical body of knowledge, am able to help them answer. So in addition to those main questions, I answer other case-specific questions. It's important to note that my investigation is parallel to that of police. I'm not responsible for tracking down fault in anybody. It's not my duty to determine whether or not there's been criminal activity or whether or not criminal charges are warranted. That's done by other agencies. These questions really dictate my mission as a medical examiner when I get around to finishing my investigation and completing the death certificate. Our case flow in Nova Scotia probably looks very much like most death investigation systems. Every case that gets reported to us has documented in our case management system the identity of the person, the time and place of death, and the cause and manner of death. Some cases clearly aren't our jurisdiction, and we call them no cases. And so we document all that information. We document that the attending physician signed the death certificate, and we let them go without any further investigation. Some cases that the provincial legislation requires to be reported to us don't actually need further investigation by a medical examiner, and I'll illustrate that a little bit later. And we no-case those as well. And again, the attending or family physician signs the medical certificate of death, and the information gets reported, but those get turned away and don't get investigated further by us as the medical examiner service. Most cases that are legally reportable to us get a further investigation by the medical examiner service staff. And in the end, the medical examiner on call responsible for that case will sign the medical certificate of death. So again, for us, our case flow, and again to illustrate a little bit around what the flow chart means and how it goes. In no cases, the body remains where death occurs. It gets transported by the funeral home that's chosen by the family, and the medical certificate of death gets completed by the attending or the family physician. We have some cases which may occur in hospital settings, which are called virtual investigations, and those are usually most commonly older individuals who have fallen and fractured a hip and died of complications of that hip fracture, where it is an accidental death because of injury, so it is medical examiner jurisdiction, but an autopsy won't add much to that investigation. So we leave those bodies locally. We investigate through medical records the cause and the manner of death. The medical examiner completes the death certificate, and the funeral home removes the body from the hospital where the death occurred, rather than bringing it to our center for autopsy. Most cases get a full autopsy, so they're transported to our Dr. William B. Finn Center for Forensic Medicine, and the medical examiner investigation is completed, including the full autopsy. The death certificate is completed by the medical examiner, and the body is transported back to the hometown, and the funeral home is chosen by the family. Again, I'll go through a little bit around the reportable deaths, which form the basis around whether or not a death that occurs in hospital should be reported to the medical examiner and should fall under our jurisdiction. For our act, anyone can call the Nova Scotia Medical Examiner Service if they think that a death may fall under our jurisdiction. We also invite people to call with questions regarding deaths or regarding imminent deaths. Sometimes people who have someone who's about to be declared dead in the ICU, for instance, have questions around how to handle that death when it occurs, and we're happy to field those questions as well, so that plans can be placed so that it's a rather seamless transition after the death has occurred and the families are aware of what to expect after the death occurs. I'm going to go through now the sections in our Act that dictate what cases are legally required to be reported to the Nova Scotia Medical Examiner Service. For those of you in other provinces, the different coroner and medical examiner acts will differ subtly in what deaths are reportable, but the flavor of what's reportable is very much the same in any of the provincial acts that I've reviewed. So it's important when doing your own to be aware of the specifics of your act, but again, this is pretty similar to what would occur in other provinces. So there's the deaths that are intuitively medical examiner cases, which are the result of violence, accidents, or suicides. And really, if there's any question whatsoever that an intoxication or an injury of any type played a role in the death should be reported to the medical examiner service. We are the ones who are resourced and tasked with sorting out whether or not it's a natural versus an accident, a suicide, or a homicide. So again, if there's any question whatsoever that it's not a natural death, it should be reported to the medical examiner service. Persons who die unexpectedly in good health, so people who do not have any medical history to explain why they have died at that time. Where persons aren't under the care of a physician, which is less likely to be an in-hospital death. Where the cause of death is undetermined, so again, if it's not certain whether it's an accident, a natural disease, or a suicide. And where there's any suspicion of negligence or maltreatment by another person that resulted in the death. So again, intuitively, if someone is involved in a motor vehicle accident, they're admitted to hospital with severe brain injury, their condition deteriorates, care is withdrawn, and they die, that is a medical examiner case because it's the result of an accidental injury. The cause of death would be the complications of that head injury, and the manner of death would be accident. And those are the ones that tend to be straightforward if the death occurs very rapidly after the injury was sustained. And most of the time, persons in hospital, the staff think to call the medical examiner service. That's not always the case, though. Sometimes the injury and the death are further apart in time, which can make it less intuitive to call the medical examiner service. For instance, in a 15-year-old with neurological deficits, including difficulty swallowing, dies of complications of an aspiration pneumonia. If those neurological deficits were due to a history of abusive head trauma as an infant, that death was the result of violence. A straight line can be drawn from the injury that occurred as an infant So the neurological death is that led to the infectious complication that led to death. And the cause of death would be complications of that blunt force injury at the head. And because it was an inflicted injury, the manner of death would be homicide. And so the medical examiner and other death investigation jurisdictions take jurisdiction regardless of the time between injury and death. And for hospitalized patients, often they're being treated for what's happening in the moment in the hospital, and it sometimes gets lost a bit in that treatment of what's actually happening right now, that down the chain a bit there was an injury in the past. And so it comes to us as the medical examiner service to sort out all the way back to the beginning of the chain that led to their death. Again, a 10-year-old suspended from a string on the blinds of his home, admitted to hospital with an agnostic brain injury, some mental health history, possible history of the choking game being played with friends. In this case, the death is a result of injury quite clearly. The cause of death is asphyxia due to hanging. And so it's fairly apparent that that should be reported at the time of death in the hospital. And it comes to the medical examiner service. It's not up to the hospital staff to have to know what the manner of death in that case is. We are the ones with our investigators and the police who will try to sort out the history to determine whether it was a suicidal act or whether it was an accidental death due to the choking. Again, a 3-year-old with severe malnourishment and dehydration who dies of complications of this, who comes from a family known to Child Protective Services. If there's any suspicion of negligent treatment, it comes to the medical examiner service. It's reportable legally by our act. And the cause and manner of death will be determined after complete investigation by the medical examiner and also by the allied police investigators. And so it's not necessary at the time of death in hospital to know all the information, to know for certain the cause and manner of death. That's really up to the medical examiner service to do that investigation and figure it out. But it is reportable at the time of death in the hospital. This case sort of illustrates that age is not necessarily a criteria for investigating deaths by the medical examiner. If there is a 5-month-old infant who's unresponsive at home that has a significant history of a congenital heart defect, and there's no suspicion that any injuries occurred, there's no suspicion that any intoxication played a role in the death, and the death occurs in hospital but a short time after admission, this would be a medical examiner no case for the most part. This infant would not have been previously healthy. This wouldn't be an unexpected death. The cause of death wouldn't be undetermined. There would be sufficient clinical information to form a reasonable opinion around the cause of death. And the manner of death in the case of complications of a congenital heart defect would be natural. So again, when determining whether deaths that have occurred in hospital are medical examiner jurisdiction, again, we'd rather have them reported to us and have the discussion than find out later about a death that should have been ours. But it's important for us to explain to people that the definition of an unexpected death varies markedly depending on perspective. Tragic doesn't equal unexpected, so it is always tragic when a 5-month-old dies. But when they have a significant medical condition, it's not an unexpected death, and it's not an unnatural death. And so we don't use age as a criteria for accepting medical examiner cases or declining. And by the same token, if there's a 90-year-old who's living quietly in the woods by himself or herself, who's not seen a doctor in 89 years, that person will likely become a medical examiner case because they won't have enough documented history to explain why they died at that point. So hopefully that's clear for now. There's a few pictures in here to break things up. This one's from New Zealand. Our Act specifically separates out in-hospital deaths and again goes through the criteria for those deaths that are legally required to be reported to the medical examiner service. Again, if there's any chance that an intoxication or injury played a role in the death, so violence, suspected suicide, or accidents, that's required to be reported to the medical examiner service. If the death is a suspected misadventure, negligence, or accident on the part of an attending physician or staff. Again, if the cause of death is undetermined. And that gets a bit gray. Sometimes the final link in the chain is not clear, the final mechanism of death is not clear, but the cause of death is very clearly an underlying medical condition, we may not take the case, even though some people think that they don't know why the person dies. What they really mean is that they don't know what that final link in the chain is, when the underlying cause of death is actually apparent. Stillbirths or neonatal deaths are not routinely ours, but if there was maternal injury involved, then we do take those. Deaths that occur within 10 days of surgery are legally required to be reported to us, and I'll talk about those in a minute. We don't take jurisdiction over most of those. By way of clarification, this is an area where the Nova Scotia Medical Examiner Service and our legislation differs a little bit from other investigative services. We aren't required to take therapeutic complications specifically, and so some jurisdictions are asked to take all therapeutic complications. Our Act does not ask us to do that. And so our threshold for accepting deaths that occur during medical intervention tends to be very high. We really limit it to accidental or intentional overdoses of medications, to a blatant malfunction of equipment that results in an injury-causing death, or to gross negligence, so procedures outside of the scope of licensed practice, to complications that are well beyond reasonable and foreseeable, and to deaths where there are serious allegations of negligence being made. Again, some of the grayer areas that we are asked to consider, but we do try to keep that threshold high. And so I always say, you know, if I decide to start performing liposuction on the weekends to supplement my income and someone dies while I'm doing that, that practice is clearly outside of my scope of licensed and experienced practice, and that would be a medical examiner case. And we'll go through a few more case examples. So a 36-year-old on a postoperative pain pump after elective surgery who suffers a respiratory arrest, and there is a serious suspicion that the pump malfunctioned and administered a fatal overdose of medication. That would be a medical examiner case. That would be a malfunction. That would be beyond a foreseeable complication, and it would be an accidental overdose in that case. So that would be reportable to us. If there's a child who's admitted for a nephrectomy or removal of the kidney for a cancer, and again, I will specify that this is the purely fictitious, not inspired by real life at all case. The surgeon decides to go for coffee, leaving the medical student to perform the operation. The medical student incises the pulmonary artery, which is a long way from the kidney, and the patient bleeds to death. That would be an unexpected death. That would, I suspect, involve serious allegations of negligence, and that complication would be beyond reasonable and foreseeable, and that would be a medical examiner case. And again, that's an extreme example, meant to be extreme, but we do try to keep the threshold that high for deaths during therapy. As opposed to a 25-year-old with diabetes who's admitted with diabetic ketoacidosis, who's markedly dehydrated and requires a central line insertion for rehydration, and the insertion is complicated by perforation of a major vessel and fatal bleeding. This would be a no case. This would be, although an uncommon and a tragic complication, this would be a foreseeable complication. This wouldn't be negligence. This would be something that unfortunately happens. It's why we sign informed consent when medical procedures are undertaken, because serious things might happen. And in this case, the manner of death would be natural, because it would be a complication of an accepted therapy for a natural disease. And the cause of death wouldn't be undetermined. The cause of death would be that diabetes and complications of treatment for. There are other jurisdictions, again, whose death investigation legislation would ask them to take these cases, even though it's a natural death and a foreseeable complication. So this is an area where it may differ province to province what would be reportable to the medical examiner or the coroner. Again, by way of clarification, tragic doesn't, for our purposes as the medical examiner service, equal unexpected, accidental, or negligent. For a woman who's 35 weeks pregnant and involved in a motor vehicle collision, who undergoes an emergency cesarean section for a stillborn, uninjured male, who was stillborn because of placental abruption or a detachment of the placenta from the abdominal wall because of that trauma. Though that is the type of case in the stillbirth where there is maternal injury that resulted in that fetal death. And so the stillbirth certificate would be completed by a medical examiner. The cause of death would be the placental abruption due to the maternal trauma. And on stillbirth certificates, there is no section for manner of death. So there's no consideration of manner of death in spite of the fact in some ways that it is an injury or an accidental act that resulted in the death of that, the stillbirth of that man. By way of postoperative deaths, someone who undergoes transplant for polycystic kidney disease and dies of complications of rejection of that kidney transplant, that death is reportable via our Act because it's within days of surgery, but for us it's a no case because there's no injury or intoxication, there's no suspicion of negligence, and it is a natural disease. And basically, for the purposes of our Act, those deaths are reportable to make sure that we don't miss deaths that should have been reported to us for some other reason that are actually surgeries for accidental injuries or, again, are reportable for a reason other than just being post-op. And again, if the death is due to a foreseeable complication of a natural disease or therapy for the disease, we would no case that death. And for Nova Scotia, I don't know about all the other acts, but there's always this sort of myth that if death occurs within the emergency department or within 24 hours of admission, or if the person's dead on arrival, that it's automatically reportable to the medical examiner service. And for our act, that's not true. The deaths are only required to be reported if they fall under the other reportable categories that we talked about. So again, a little bit of grease to break things up. Deaths in custody do also come up. Deaths while people are in custody can occur in hospital. So anybody who's been being detained or in custody of a correctional institution or a peace officer, or is in custody under the Children and Family Services Act, or I suspect most other jurisdictions, whatever your similar Child and Family Services Act is, when that death occurs, it is a medical examiner case. It is reportable to us, regardless of the apparent cause and manner of death. So even if it is a child or an older person with a long history of a severe medical condition who dies as a result of that medical condition, even without absence of injury. So this example is an 8-year-old with status asthmaticus who suffers irreversible hypoxic brain injury of which they die. If the person is in custody under, under the Child and Family Services Act, or if it's an adult in custody in a federal penitentiary or a jail, regardless of the apparent cause and manner, that death becomes a medical examiner case, and that's to ensure an objective investigation that's done into that death to ensure that there isn't anything, there wasn't any maltreatment of that individual, and to address any questions that other investigative agencies or family members may have that will come up later. A little bit of Rome. So again, back to the flow chart. So in considering in Nova Scotia our legislation, either the medical staff looking at the legislation and deciding whether the death needs to be reported or reporting to us, we look at our legislation and decide whether or not the case is going to be accepted as a medical examiner case. And if not, there's a note in the flow chart to follow the usual death of a patient protocol for non-medical examiner cases. If it is a medical examiner case, and our service decides to accept jurisdiction, then we've asked the reporting person to ask a few questions so that everything can start being planned and put into the work. So can the clinical armband be placed if it hasn't already been placed, so that there's some continuity just within the hospital of who that person is? What's the medical examiner case number, because that helps us all talk about the same case and ensure we're on the same page. What's the expected timeline for arrival of the medical examiner staff if they are coming to the hospital to respond to the scene there? And also to ask up front about parents or loved ones holding or touching the remains, the body of the deceased person. and I'll go through that. But that's a question that needs to be discussed sooner rather than later so that a firm decision can be made and the decision communicated clearly and consistently to all family members and staff. Per our Act and per most death investigative acts, once the case is accepted as a medical examiner case, interaction with those remains can only occur under the direction of the medical examiner and the medical examiner staff. While this interaction, any interaction is occurring and documentation of all interaction is ongoing prior to the arrival of our medical examiner staff at the hospital, there are things for that the families need to have ongoing as well, such as bereavement support, and there are other processes in hospital that need to be ongoing just when any death occurs in hospital. But it is important to remember that the interactions with that remains now needs to be only under the direction of the medical examiner. And our Act very clearly states that. It separates it out. It's a section all to itself where no person who has reason to believe that the remains are of someone who died under circumstance in the Medical Examiners Act, the Fatality Investigations Act. No one can clean or make alterations to the body or to any objects attached to the body or to apply any chemicals or other substances either to the outside or the inside of the body except under the direction of the medical examiner or the chief medical examiner. And that can be either the medical examiner, and often I, as the medical examiner, am speaking through my investigators. And so in remembering that it is actually illegal to clean the body, to remove clothing, to remove medical equipment, to apply inks or jewelry to the body, or to transport the body anywhere if the medical examiner doesn't know about it and has notified it. And people can be charged for that. So we want to make it very clear to people so that they don't inadvertently do something that will get them in trouble later. Clearly, that act doesn't apply to anything that's done in the name of resuscitation. So when death hasn't yet been declared, it's fair game. Clearly, the goal is to attempt to resuscitate the person, and substances are applied to the body, equipment is applied to the body, drugs are applied into the body, and that is all in the name of resuscitation. And until death has been declared, it's not the medical examiner jurisdiction, it is the clinical jurisdiction and the clinical judgment that is the important factor. However, after death occurs, loved ones, when we had to be very clear about this because there were not consistent messages being given to families, and our staff, there had been changes in our practices that weren't clearly communicated. And one of the worst things that we can do to staff and family members is give inconsistent messages. If you at least give a decision early on, in my experience and in what we've heard from family members, if you at least express a decision early on and are consistent about that decision and can justify the decision, people will deal with that. But if you change your mind several times on the way through, it's very hard for people to deal with. So up front, loved ones are not to be allowed to hold or touch the body of an infant or child or the remains of an older individual unless allowed by the medical examiner. So it is the decision of the people investigating that death, which is the medical examiner service and the police. The decision is based on very case-specific factors, and it isn't fair to task hospital staff with that decision. It's not the hospital staff who have to sit on the stand later when a case goes to trial and justify what was done after the death occurred. And so it is the medical examiner, both legally and professionally, responsible with making that decision. It may not be allowed. In some cases, the loved ones may not be allowed to touch or hold the remains of that infant, child, or person who has died in hospital. The interactions with family members will always be supervised by someone, either the medical examiner, the police on behalf of the medical examiner, or hospital staff, and all the interactions will be documented. So we put into the flow chart that this should be discussed up front, and we've put into the flow chart and put into the education sessions so that staff know that it's the medical examiner who will be making the decision about holding the body, so that the medical staff do not assume that it will be allowed, but that we ask the question early and allow for early decision making and consistent communication about what that decision is. And so that means in pediatric hospitals, most commonly, memory boxes are created sometimes when persons die in hospital. and those can't be done on remains prior to autopsy if it's a medical examiner case. But what we decided for our flowchart was that the best way to ensure that the memory boxes occurred if families wanted them, and they were very important to many of the families, was that to provide that material to the family so that they could have that memory box created after the remains were released to the funeral home. And the funeral homes often help, or are a great help in making sure that that's done. We also thought it was important, and we emphasized during our training sessions, that personal effects that are transported to the medical examiner service with the body will almost always be released back to the funeral home. So when you have a body that's died in hospital and there's jewelry on the body, there's clothing on the body, there's personal effects with the body that the family, that's very important to the family, those aren't being lost to the family just because they're being transported with the body to the medical examiner service. In almost every case, those are documented, cataloged, and released back to the funeral home and through the funeral home to the family members. So they have to be left with the body. They can't be tampered with legally, but the families still get those back. So we try to reassure everybody that that's what happens. And again, because the memory boxes were so important to family members and to staff, they are highlighted on this flow chart that they will be offered and reviewed with the family so that the family will take those away with them and have the comfort of knowing that they have control over getting that done if they want. And it goes with the directions to help the funeral homes or whoever's creating that memory box get it done. We are sticky about this. One, because it's in the Act that I had no part in writing, that nothing's to be done except under my direction. And two, because we really are responsible for attempting to maintain the same standards of continuity regardless of initial levels of suspicion around the case. It's not possible to predict every case that's going to go to court. And for those that do go to court, there can be significant issues around chain of custody, contamination, and the introduction of artifacts after death. I recognize that there's all kinds of handling of a body prior to death during resuscitation, but from the moment death is declared, it then becomes my responsibility to justify everything that's done to protect whatever evidence remains after the resuscitated process. I've had questions about cases of individuals who are in the ICU for a significant amount of time and then death is declared and they die in the ICU. And in those cases, often the memory box part, fingerprints, footprints, locks of hair, are collected prior to death being declared. And clearly I have no jurisdiction until death has been declared, and so that's fine with me. My suggestion would be, if it is a criminal case, that you talk to police, because it's their trace evidence that they may be interested in, that they may want to collect again before much is done with the body. Clearly, tissue and organ donation is significant handling of a body once death has occurred prior to medical examiner and autopsy performance. And so we as medical examiners do have to give consent prior to tissue and organ donation occurring, and almost all the time we're able to do that. We just need to know that anything that needs to be collected has been collected evidence-wise before it occurs, and we may want to take photographs prior to the tissue or organ harvesting occurring so that we know what injuries were present before that versus what was introduced as an artifact of that process. And that's Peggy's. And again, once the case has been accepted as medical examiner jurisdiction, there are still lots of forms that are hospital specific that need to be completed. And so this is a reminder that that documentation needs to be completed as well while awaiting the medical examiner arrival at the scene. There was a part in the chart around a time of arrival of the medical examiner service. So if the remains are in the unit or in the emergency department, is the fact that those remains there affecting the clinical operation of the unit? And if they are, we've encouraged people to follow up with the medical examiner service to see what the expected time of arrival is. Has it been changed for some reason? Because as you all know, life gets in the way sometimes, and you can have 3-5 days in a row and then have 50 things happen at once. So it has something come up that's going to delay arrival at the hospital. And if that's the case, can those remains be removed to the hospital morgue rather than remaining in the unit? And so we put in the flow chart a procedure for taking medical examiner cases to the morgue, documenting that they're there, securing them in the morgue, and completing the logbook. Pardon me, I've still got a little lingering cough from a cold. Sometimes those remains can't be removed to the morgue if it is a particularly suspicious case, and there are issues around continuity, or if the medical examiner or investigator is in the parking lot and about to arrive on the unit, then they may not be transported to the morgue. And again, the clinical team will stay with those remains and continue to document the interactions with the remains and the family. And then if the medical examiner is responding to the hospital, the medical examiner will arrive at the clinical area. And when the medical examiner or the medical examiner staff arrives, our mission, again, per our Fatality Investigations Act, is to figure out who the person is, when and where they died, what the cause of death is, what the manner of death is, and to answer or find out what any case-specific questions there might be from other investigating agencies or the clinical staff. So these are the questions when we arrive at the scene that we're collecting information to help answer to make the final determinations of cause and manner. The medical examiner service may be represented at the hospital by a nurse coordinator of investigations, a nurse or paramedic death investigator, by a police officer who's operating on our behalf in addition to his or her role as a police officer, or by one of us, the forensic pathologists, medical examiners. And it is the medical examiner who is directing all of these other people, even if not present in person. And again, the Act specifically allows RCMP or municipal police officers to act on behalf of the medical examiner's service. And in order to answer the questions that are laid out for us in the Act, the medical examiner service has the power without any warrants to enter a place where the body is. So we're entering the place where death occurred or where anything we think will help answer those questions occurred without a warrant under our provincial legislation. We're able to take possession of things like medications and equipment that we think may help us determine the identity or cause and manner of death, including antemortem blood specimens if we think toxicology testing is going to be pertinent in the cause and manner of death. And I won't go through all of that. We also get medical records without a warrant to help us, again, answer who the person is and to answer the cause and manner of death. And so we don't need a warrant, whereas police, if they need medical records for a criminal investigation, will require their own warrant to do that. Let's keep it. Once the medical examiner service, whoever's representing us, arrives, we will ask the clinical team to help us a little bit and give us a bit of the history and help us get the medical records. But it's not really the clinical team's responsibility anymore to document the interactions. We really will be taking over at that point. And we'll be there usually until our removal services transport company arrives to take the remains out of the clinical area. And we have a contracted removal service for transport of the remains, and they are the only ones who should be moving bodies on our behalf. They'll bring them to our center for autopsy, and they are also the ones who are required to transport the body to diagnostic imaging as required. So most of our pediatric cases go for postmortem, CT, and X-ray. And it's not up to the hospital staff to be tasked with that. We don't want to tie up clinical staff with that. Once death has been declared and it's a medical examiner case, it is our transport service that transports the remains anywhere else they need to go. And again, we highlighted on the flowchart that any post-mortem diagnostic tests that are ordered, the requisition has to be completed by the medical examiner office. There was some confusion around clinical staff being asked to complete requisitions on our behalf, and that isn't appropriate. Anything that's ordered after death has been declared in a medical examiner case should be done by the medical examiner. We also clarified that the Vital Statistics Act says you can't take a body out of the hospital without a medical death certificate. However, our act overrides their act, and we can remove the body without a warrant for part of our medical examiner investigation. And again, the little bit at the end is once the remains have been transported from the hospital, there is paperwork to be completed by the hospital that indicates where the remains went, because clearly when a patient dies in hospital, there should be some record of disposition of those remains. And so there is a logbook at the IWK where the medical examiner case number is recorded and the fact that that patient was a medical examiner case and was released to the medical examiner service. We also clarify and educate around the fact that we don't, as a medical examiner service, require consent to have an autopsy performed on individuals as opposed to clinical autopsies in the hospital. So in medical examiner cases, there's no requirement for nursing or physician staff to obtain consent for an autopsy to be performed. The autopsy, if needed, will be performed without consent from them. So at the end of the investigation by a medical examiner, the work product is the death certificate, which states, again, the identity of the person, the time and place of death, and the cause and manner of death. And the time for this to occur varies greatly depending on the complexity of the case. I'm not going to go through that in this case. We also like to highlight that the final autopsy report in that work product, it's released to the next of kin automatically according to the Fatality Investigations Act. And according to the Act, the chief medical examiner has to consent for that report to be released to anyone else. However, it should be fairly easy for treating physicians to obtain access to that. We try very hard to close the loop if clinical staff want to follow up on deaths that occurred in hospital to find out what the autopsy findings were, to find out what the ultimate cause and manner of death were. And so by written request, they can obtain the autopsy report in any cases that they were involved in. So again, this is the flow chart, which was the product of a lot of time and consideration, and it, I think it turned out quite well as far as being fairly clean, and I hope that, the lecture sort of provided some of the background for the decision making around what boxes we included and what we were trying to get across to people. And again, it's because the deaths of a patient occur when everything's busy and they are upsetting to people, and it occurs at 4 o'clock in the morning. And so the hope was that this would simplify the process and make it much more consistent. And again, it's because it's that consistency, the decision making and the clear communication to families that seem to make it much easier for families. What is going to be a difficult situation anyway is only going to be made more difficult if people are unfamiliar with the process and aren't clearly and consistently communicating what the family should expect at all the different steps. So that, and staff as well, were actively unhappy when they didn't understand the process and when they didn't know what the next step to expect was. And so the hope is that this flow chart alleviated a lot of that confusion and inconsistency. So that is the end. Thank you very much for your attention. Again, questions now, welcome. And I also have my email address there and my phone number. There are often questions that don't occur to you until later in the day, so you can follow up with me if you want. Thank you.
Thank you very much.
That was great, Dr. Wood. Lisa, do we have any questions?
I have one from Lucinda. What is the established protocol for medical staff to respond to families' requests for medical examination when that has not been initiated or presented by staff?
Could you just read the question again? Sorry.
So, what is the established protocol for medical staff to respond to a family's request for medical examination when it's not been initiated by the medical staff?
Oh, so if a family is requesting an autopsy in a particular case, you're welcome to call the medical examiner service and discuss the case with us. And if it falls under the medical examiner jurisdiction, we will accept it and perform an autopsy. Really, in almost every case, we take jurisdiction over a complete autopsy performed. If it doesn't fall under, pardon me, if it doesn't fall under medical examiner jurisdiction, then it would be up to the clinical pathology team. If the family is requesting it, then clearly they're willing to give consent for that autopsy, and it would be up to the clinical pathology team to take that.
Okay. Thank you. I don't have any other questions right now. We only have a few minutes left in our hour, so if anybody has any questions, please type them in, and we'll get to those. I don't know if Fergal, Darlene, or...
I'm a slow typer, so maybe you can forgive me and let me ask this in real time. Marnie, thank you for a great presentation, and I would love to talk to you about this another time offline. Can I go back to the piece where the family get the autopsy report?
Mm-hmm.
So I have two questions. Sometimes these reports can be either very, for want of a word, brutal or very complicated. Some jurisdictions actually do a more sensitized and less complicated report. What has been your experience around that?
I wasn't clear on that, I guess. What the families get up front is a certificate that just states the cause and the manner of death. Right. And they also get a verbal report from our nurse coordinators.
Okay.
So the nurse coordinators will call and we'll introduce some of the findings, and then we'll answer questions as they're presented rather than launching into a long explanation.
Great. And my other thing is, sometimes you get these unexpected deaths in childhood, and your primary brief is to exclude, bad behavior as in violence. And then you come across something that is actually a metabolic defect with family implications. Who kind of pursues that for the family?
It's generally we as medical examiner will pursue the cause of death. So if it is metabolic, then we pursue the testing as possible to be performed. And we usually do that in conjunction with our pediatric pathology consultants, because at that point we require some extra expert input. And then we generally send the families to their own clinicians and to genetic or metabolic.
Okay. And if it's possible, I'll ask one more question. I will keep quiet after this. Do you, on a regular basis, review your cases for trends? And I'm thinking what you talked about, the little boy who was maybe playing this pretend suicide game with the curtain hanger or whatever. These things can become a little, you can develop clusters of these things. And do you kind of try and see in the body of the cases you've done over a period of time, are there clusters, and if so, what would you do about that?
We are not currently well staffed or resourced to do adequate surveillance. We want to be, and we're working toward that, and we would love to have, I know other jurisdictions have surveillance committees. We informally try to figure out who we should be addressing when these things occur, because we are provincial, so we are the ones who are going to notice the clusters. And
that's right, yeah.
And we do try informally to inform whoever we think would be the best agency or body to be notified of that. But we're not well resourced or staffed right now to do that very well.
Thank you very much. Great presentation.
Great, thanks. And yeah, contact me anytime, Fergal.
Thank you.
And it's Darlene. I'll just make a comment that goes along with the presentation. As Dr. Wood referred to other forms and other processes at the IWK, we took probably a year, and we actually hired a co-op industrial engineering student to actually help us work through a lean methodology to lean all of the processes around our morgue and our death of a patient, knowing that medical examiners' cases were kind of an outlier for us. And so we did all of that work prior to engaging with the medical examiner's office to figure out this piece. We have 5 intake ways and 5 different intake processes for our entering into our morgue, and the medical examiner process was one of them. So if anybody's interested in more of the work that we did prior to the work that Dr. Wood outlined today, I'd be happy to talk with you about that, or you can contact me via email as well. So I think our time is up and maybe a little over. So I would like to thank Dr. Wood for highlighting the work that's been done. Hopefully it was well received on the other ends, and you can see the applicability for your own individual processes. And please join us on our next Patient Safety Collaborative call, which will be taking place on February 27th at the same time. So stay tuned for that, and thank you everyone for being on the call.
Thank you, Marnie. Thank you, Doreen. Thank you, everybody else.
Thank you.
Darlene.
Take care. Thank you.
Marnie, bye-bye. Bye, everyone.